comes to gender affirming, so that the healthcare workers could understand what transgender means. I've also created a platform for engagement within the community, where we have sensitized the local gatekeepers on how to identify trans persons within the society and how they are supposed to be treated within this community. Yeah.
Thank you so much, Courtney. And I think we can now hear from Christina about your experience. Have you faced it? Have you seen someone face it? You know, as a person that is working in the HIV field.
Thank you very much, Josephine. In this field of HIV interventions, whereby we work with key population and people living with HIV, we understand that stigma and discrimination is among the key issues that hinder access to services to the community and to the key population. So I would like to say that, key population, I work with the key population and I've seen people experiencing stigma and discrimination. People have been talking about issues of disclosure of their HIV services, verbal abuse by healthcare providers, where there's also situations whereby they share the HIV status of people without their consent, which is undermining the people themselves to the extent that people decide, like, I would rather not go to this healthcare facility to access services. We've also seen key population even moving from one facility to another because they feel like from this facility they don't receive services, adequate services as per their needs. So with that in mind, also we've also seen key populations who are also working in the HIV spaces, even like as healthcare providers. They're being stigmatized. For instance, there's a case in Tabora, I think, whereby there's a trans woman who was a healthcare provider, but at the end of the day, she was dismissed from work because of her gender identity. This gives you a chance to reflect. You can imagine this trans woman, how many hurdles she has gone through ever since she was a kid to becoming from all the way from primary school, secondary school to the college, whereby she started to be what she wanted, just to earn a living. Yet, just because of her sexuality, she was dismissed to work. So we are really trying. The government is trying to do the sensitization programs, but at the end, is it really working? Is it really working if someone can be dismissed from work simply because of their gender?
Thank you so much, Christina. And we'd love to hear from the male perspective. You know, we all know that male involvement is key in HIV prevention, but also treatment and everything. And we all know that we are fighting to ensure that men are on board and men are involved in all programming. So I would love to hear from the male perspective in terms of stigma and discrimination that is related to HIV. What has the experience been like for the males in Tanzania? Thank you.
Thank you so much. I will talk about mainly in two aspects. One is the expectations around gender roles of males in the families. Men in most of our families in Tanzania are expected to provide for the family. Expectations as one of the divisions of roles between males and females in the family. And so when a man comes out and discloses that he's living with HIV, there's a feeling like he has brought shame to the family, and so he starts blaming himself and trying to hide out of the public, but also it reflects in terms of taking the medication, but also for other men to appear for testing services. and in most cases you find dropping out of treatment because of the felt conditions, feeling that have to blame and have to be blamed in the family, about shame, and how will the family and the neighbors look around me. That is one aspect. But again, what relates to that is the culture that the masculine behaviors that men have in the society, which relate to intimate partner violence. Like, for example, when a wife or a woman comes saying that I'm HIV positive or I'm taking medications, it becomes a factor for bringing violence in the family. And I've seen cases in Shinyanga, for example, last year we were doing the Father's Day in Shinyanga, and a lot of men came out and saying these are the problems. Violence in the family starts and contributes to a woman or a wife dropping from treatment as well. So even in our Council of People Living with HIV in Tanzania, we have around 700,000 as members registered through clusters, but men only, they are only 38% who come out and say, I want to be registered in the council. This means that men are hiding, and this is just because of the cultural and gender roles expected out of men. Thank you.
Thank you so much. Indeed, that gives us a clear picture that men are hiding. We need to know where they're hiding so that we can go and get them. Thank you so much. So we can also hear from you in terms of men. What have you experienced? Stigma and discrimination. Have you seen other men experience it in our society? Maybe they're going for the services. Maybe they're providing the services themselves. Thank you.
So thank you very much. My name is Mtale Chonta from Zambia. I come from an organization called 3C Regional Consultants. It's a private firm, and we've been working on developing stigma toolkits and other materials, but for the last about 14, 15 years thereabout. And so I carry quite a lot of stories from across over 26 African countries where we've been working. And the story is similar to what my colleague here just shared about loss of status in a cultural perspective in a masculine society. And that begins to lead to men to feel like, look, I'm not important enough, and so that they begin to lose the decision place, as it is often referred to. Of course, most of this is toxicity, masculinity. But in addition to that, other experiences, and across the spectrum, we've seen things repeating themselves, forms of stigma such as violence, which was touched on in the morning, and then finger pointing, labeling, insults, facial expression, the general things, neglect, where a person is maybe living with the virus or is identifying a different gender or has a particular sexual orientation, and the person is neglected, is not supported. So across the spectrum, different lenses, you find that these are the commonalities of forms. If I may quickly add, I think when Bernard was presenting about violence or anticipated stigma, or internalized stigma rather, he mentioned about hiding a pack of medicine. There's an interesting book, if you can look it up. It's called Hidden in the Millennium. So Hidden in the Millennium takes you through a process of a woman who is married and is on ART treatment, but she cannot disclose to her husband. And those are, perhaps we haven't gotten there, but those are the consequences of stigma. It is because it's so rampant that it is easy to internalize. And so perhaps I can end there, but just to say that the forms are pretty common across the board.
Well, thank you so much. And lastly, to Elizabeth, the young woman on the panel, have you experienced stigma as a person, or have you seen someone within your circles experience HIV-related stigma and discrimination, and how was it?
Okay, thank you for the good question. And before passing through the question that you asked, I will shortly pass through the definition here, therefore, we'll be in the same page. And shortly, generally, as stigma itself is a negative stereotype, beliefs, actions towards people living with HIV/AIDS. Okay, so I will share some few experiences generally, because there are so many experiences, varies from one place to other place, varies from occasion how it's appear. So by experience, there are stigma occurs from one itself, we call it self-stigma. There is institutional stigma, there is community stigma. So stigma itself is a wider thing that we can't disintegrate it into events. So we can discuss stigma by grouping, as I already mentioned. Okay, I will also share this report of 2017. This is Tanzania HIV/AIDS Impact Survey. They share as described as among young people and adults aged 15 and above, 25% reported discriminatory attitudes toward people living with the HIV. And also stigma in Tanzania appears in different faces depending on gender matters, depending on level of education, depending on one places to another, because we are seeing several cases reported from rural areas compared to urban areas. So generally, we speak stigma and discrimination. It's a very big issue, and in Tanzania it's appeared difference as according to the categories already mentioned. I'd like to share in Swahili so as you can understand me well. There is some example here. Kuna watu wananyanyasika kwenye workplaces. Watu wengi sana wananyanyaswa na wanakosa wengine ajira kwa sababu tu ya status zao, wengine pia wanakosa masomo kwa sababu ya status zao. Zipo ripoti nyingi ambazo tukisema to digest into events, tunaweza tukajaza a lot of books and chapters. So stigma exists and is a very big issue in Tanzania. So as to combat it, we need to involve everyone in KDPs. We need to invite in different groups. Most we want to invite the people who are infected with this issue. Watu ambao wanaathiriwa zaidi, ambao wameshakutana na hiki kitu, ndio ambao unaweza share best experience kwa namna gani wanaoishi. So kulingana na experience yangu na vijana ambao nimekutana nao, vijana ni wengi zaidi. Wengine hadi wanashindwa kuolewa kwa sababu ya hizo status zao. Ndio tunafahamu. Kwa hiyo ni kitu kikubwa, and we have a big amount to climb. Thank you.
I will translate a little bit to what Elizabeth was saying. She said that many people are harassed in their workplace and also in their educational settings due to their HIV status. And then she also said that young people are experiencing a lot of stigma, and they're really, really affected, not only infected but also affected, whereby we have seen experiences whereby even young women cannot even get married because of their statuses.
Thank you so much for that translation. So from the experiences we have had, and probably from the experiences that you have and the experiences that you have had, stigma is a real thing. It is affecting the men. It is affecting the key population. It is affecting the young people. It is affecting all of us from actually accessing health services. An experience that I have also witnessed, probably maybe it is here in Tanzania, is that you find that even health workers, as long as you're working with people that are living with HIV, there is there is a tag attached to you. So people usually think whoever works in the HIV field is HIV positive. And sometimes you find health workers trying to, shy away from working in the art clinic or shy away from working in the HIV space because they will be tagged to be HIV positive as well. So as we discuss in this next phase with the panelists, what is it that we can do to ensure that we curb down stigma and discrimination in Tanzania? Thank you. I think we'll start with you, Christine.
Thank you very much, Josephine. We understand that stigma is caused by many issues, including structural barriers. There's also internalized stigma, there's the institutional stigma, also stigma in the healthcare systems. Not only that, we also have our cultural beliefs and social norms that play a major role in fueling stigma and the perspective of the community on how they perceive people living with HIV and key population. So for me, I would advise that we have laws that criminalize key populations. So we can try and see how we can use this law, like navigate on these laws and decriminalize maybe key population. By doing so, it will encourage key population in accessing services, because you will, at one point, we understand there are policies that provide for the access of HIV services to key populations, but on the other hand, we have the laws that are criminalizing. So despite the fact that you have the policies, people would feel uncomfortable because how safe am I when I go to those healthcare settings to access services? Well, what is the effect of me being a key population? What if people know who I am? What next? You understand what I'm trying to say. So we should try and sit down and see how are we going to intermerge the laws and the policies so that we ensure access to services to everyone is suitable to everyone, despite of gender identity or their gender identity or their social status. Another thing we'll talk about when it comes to internalized stigma, we should have programs that whereby people can come together and discuss the key issues, and also design programs that people are comfortable. And while designing these programs, we should ensure that the people who are highly affected by stigma should be at the center of designing this program, rather than just going out there, you design something for people, thinking or assuming that this thing is going to work, yet the people themselves are not in the middle. You might put in resources, but at the end of the day, it will be just no use, because will these people really embrace whatever programs that you've designed? In the healthcare systems, I would also advise we should have standardized behavioral change programs in the perspective of public health. I believe in most HIV interventions there is the SBCC component for key population, but these programs, they're not standardized. So each and every person that is implementing these programs is doing the programs as per their own perspective. And also designing the SBCC programs, we should involve the key population, because people, they're just doing whatever they feel is right, yet is it really working? You might think that you have an SBCC program that will encourage people to come and access the services, but in the end, those programs are shunning the people away from their programs. Also, yesterday there was a participant who suggested the behavior change programs for their providers, which was a really good suggestion. So I think we should adapt to that, because also the attitude of the healthcare providers play a role on how people access services in there. Thank you.
Thank you so much, Christina. Is it really working? That is a very important question, because sometimes we do activities, we do projects, and we think they are really working, yet actually they are not working. So as we move forward to taking on projects that are targeting stigma and discrimination reduction, we should have that question at the back of our minds. Is it really working? To ensure that we get lessons learned and we get recommendations, so that we know that whatever we are doing is actually working towards reducing stigma and discrimination. And the other thing that I want to pick from her presentation is she talked about involving the people that are affected. And this has been a common statement, I think from 2016. I started hearing it in 2016. Nothing for us without us. Since then up to now, it is being said. And I ask myself, are we really involved? Is it something that's going to be said all the time, but then nothing is done about it? So as we look at involving the beneficiaries, involving the people that are affected most, we should ensure that we listen to them. I think that is the most important thing. Sometimes young people or the beneficiaries or those infected are called in meetings, are called on platforms, and then before you know it, it is just attending a meeting and that is it. But do we listen to them to ensure that we involve and we incorporate whatever they are saying into the design of the programs that we want to standardize in the country? Thank you so much, Christina, for that. Over to you, Courtney. What strategies should we look at in Tanzania to ensure that we curb down stigma and discrimination?
So one, should help institutions recognize stigma. By helping institution is by checking on the environment where people are accessing care. Is it a platform for expression? Is it a platform that somebody can come out and say that I'm living with HIV and these are the best practices that I've been doing that have made me to adhere to the medication? So secondly, we should also address social stigma to the environment. As the same way I was talking about institution, those environment that these people are coming to access services, is it well conducive for them to also engage in other activities? Then we should also respond to the needs of stigmatized population. For example, I'll say that I was stigmatized, so what kind of response should be given towards my stigma and discrimination attack that I got? So through response, we are able to identify those stigma and we are able to address them as they arise. We also use media to showcase that AIDS has a human face. So for example, we can involve people who are talented in doing drama or doing music. Somebody can sing about stigma and discrimination to expound more to people to understand. So I understand that through this media, it's also very easy for, actually if you have the posters that are posted in these different institutions, people are able to read them and come up with solutions when it comes to stigma. Then we also engage the community. And in terms of engaging the community, we are looking at the caregivers. Are we having a community where we have caregivers who are able to take care of people who are living with HIV? Are we having a community where we have social health workers who are able to identify these people within the community and address issues when it comes to stigma? And then also I will talk about expand ART therapy. When we're talking about therapy, we are looking at the differentiated models. Do we have community-based differentiated models that address stigma? Is it a therapy that enables someone to come freely to pick their drugs? Because nowadays we know that facilities are more congested, and we have individuals who are not able to come to the facility because of stigma. And I thought that doing expand ART therapy could be the best practice actually to reach those individuals who are not able to express themselves or who have not yet accepted that they are living with HIV. Because for somebody to accept and see that he's living with HIV comfortably and is able to come out, it's normally a process. It is something that somebody cannot just wake up today in the morning and just say, yeah, I'm living with HIV and I'm ready to take the responsibility. No, it's a process. Because first you have to internalize yourself, accept yourself, then accept that you are hosting virus in your body. Actually, you're not even living with it, you're hosting it. Because it's something that I have control over. If I decide that today I don't want the virus to multiply in my body, I will decide to take my medication. But if I decide not to control it, then it will also control my life. So one of the best things that you should understand that we are hosting the virus. Once somebody understands that he's hosting something on himself, then he has a responsibility towards it. Thank you.
Thank you so much. From the conversation there, I want to put some emphasis on community engagement, and especially the caretakers, as you know it was stated. I always share with my peers that I think I can withstand stigma from school. I can withstand stigma from my friends, but I cannot withstand stigma at home. Because just imagine if you're at home and you're being stigmatized by the people taking care of you. I mean, that is the worst thing ever. So as we look at engagement, let us not forget, and not just the caretakers, but the primary caretakers of our children, of our people, of our young people there. Because the worst case ever is to be discriminated or stigmatized at a place where you think you're meant to feel loved and feel safe at the end of it all. So I will proceed to this other side to understand what strategies can we think about to curb down stigma and discrimination. Maybe we can learn from Zambia.
Thank you very much. First of all, there are multiple strategies, and I think that's one of the things we should never neglect. We should always remember that stigma is a complex, and as complex as it is, it needs multiple strategies. Not one strategy fits all. So I do agree with Courtney. We think about the community, we think about the home, but we also think about other places. In 2018, we were privileged to develop a strategy together with the Ghana AIDS Commission. And so together with the Ghana AIDS Commission, Health Policy Plus, and US Agency for International Development, we strategized an intervention which began with a baseline. And the reason we did a baseline is because when you visit health facilities, almost every health worker might even tell you that no, here we do not see people being stigmatized. Why? Because often they do not actually see how stigma looks like. They are unaware. Where we are seated here, you might not know that you're actually stigmatizing. From yesterday to today, perhaps you may have been stigmatized. It could have been in your attitude, it could have been in your asking, it could have been in your approach to someone. You did that maybe even unknowing, others even knowing, deliberate. So when we get to that point, then people begin to see, and it's fantastic when you do the baseline, because it was a questionnaire online, very anonymous, and people started saying, I didn't know that this actually happened at this particular clinic. I didn't know that we do this. I thought we were trying this, I thought this is PPE. I didn't know that it had an element of exaggeration because I knew the person's status. So once we did the baseline, we did a total facility training. What do we mean? We mean bottom up, from the gate man, from the receptionist, throughout to the health providers until top management. Often we have trainings which are piecemeals. You train management and you hope the management are just going to tell the staff. But you need to adequately attend to individuals. the guy at the gate, the way he's looking at people who are coming in, the way he's addressing gender issues. So once you do that, then the whole facility is aware. So we have had very interesting, and I'll share the report with the conveners. We have had very interesting reports where a gate guy, the guy at the gate, approaches the nurse and challenges the nurse and says, but isn't this stigma the things we learned about? That's fascinating for me. That's really a good experience. Because as much as I'm seated at the register, when I see a doctor ignoring a certain group of people, I can tell that, how long have you been here? You've been here for an hour. Why is the doctor not attending to you? And the registrar or the person at the registration point, but I can tell. Then afterwards, at the end evaluation, what's the impact? Create those stories. And again, I'm going back to Bernard, when he talked about, it's very hard to quantify stigma, okay, the impact. But at least we can use qualitative methods. We get those different anecdotes, different stories. Then eventually cascading. Why? Because stigma is the reason you go to your religious places. You will go to church every weekend. You go to your mosque maybe every Friday. It is not because you haven't understood the Quran or the Bible, but you need reinforcement. We went to ask someone will say, no, me, I was trained as a stigma trainer in 2003. And that was the only interaction we had about stigma. So over time, the information cannot be sustained. So they need reinforcement. They need going back, having different activities to remind them about stigma. And some of them could be a simple picture stuck on the wall. Just a simple picture stuck on the wall of a person stigmatizing. Whenever you look at it, you think about it. So perhaps I can end here. And perhaps very crucial, establish at a health facility a complaints and a compliments corner or committee, so that people can say, I have been to your health facility and I'm happy. I didn't feel isolated. Or I was at your health facility and I was told to go and change clothes before I could be attended to. So those are aspects. Then you begin to monitor what you are getting. And then it is a red flag or it is a green flag. If it's a red flag, retrain. I will end here.
Thank you so much. Compliment and complaint corner. Sometimes you want to just complain, but I think we can also compliment the good that is happening at the health facility. Thank you so much.
Thank you. I want to go back to the participants. And one of the most important things in stigma reduction or stigma elimination is, where do we talk about stigma? Are we talking it in the office? Are we talking it at home? Are we talking it in conferences like this? And does that translate into actions which we are supposed to do individually in terms of addressing the issues that we discuss where we do? And that is very important. But the second thing I echo my colleague from Zambia is about the information generation and how we deliver that to the public, the messages, and how do we gather this information. And do we see the variations in terms of the data that we are gathering? For example, I said earlier that we are doing community-led monitoring, and lately we have done up to 38 councils of Tanzania. And one thing that we noticed in March 2021, the levels were up to 8%. In September 2021, we have results which show that from 190 facilities, stigma was around 6%, slightly higher from the national average which came out of the stigma index study done by the government. But again, when we kept on analyzing information from other councils, in June this year, it went up to 11%. So these variations are telling us something, that things are not clear in the environment where we are providing services or where people living with HIV stay in the community. So this is one thing that I want to humbly raise to the government and researchers, that sometimes when we do studies, they help in terms of giving the picture, but we need to put effort into translating that into real actions and monitor those actions to curb stigma in our society. I will give an example. For example, the last stigma index was done 2 years ago, and the previous one was done in 2012. The difference was around 9 years since we do the national stigmas. And this does not give the real picture in terms of the change, because so many things happen in the diversities. You can imagine us in 3 years, in 2 years, we have seen the diversity in terms of the levels and percentages of stigma in the society. So researchers, the government, please collaborate with the community of people living with HIV and regularly check and provide. Perhaps we need to develop a national dashboard which gives the picture of where we are in terms of addressing stigma in the country based on the findings coming out of stigma index studies and various researches like the one which is being done by a colleague from Ifakara. And when we stage the dashboard, we need to invite people living with HIV, key population, all those groups which are experiencing stigma in their society. Another